question is asking, Pierre-Robin sequence has been shown to be associated with which syndrome? Down syndrome, Stickler syndrome, Turner syndrome, or Klinefelter syndrome? Now, before we can talk about what syndrome Pierre-Robin sequence is associated with, let's first talk about what the Pierre-Robin sequence is. Now, Pierre-Robin syndrome is an uncommon congenital birth defect characterized by a triad of conditions, and it's also known as the Pierre-Robin sequence. It's known as a sequence because one component or finding leads to the formation of another, which leads to the formation of the third finding or component. Basically, it's a series of events dependent on each other. The first event in the sequence is the underdevelopment of the mandible as the fetus develops. This underdevelopment prevents the tongue from growing and developing in the correct location, forcing it to be pushed up and back into the upper airway. Because of this displaced location of the tongue, the palate is blocked and unable to obtain full closure, resulting in a cleft palate. And this is that triad of components associated with this sequence or syndrome. Underdeveloped mandible, leaving no room. Now, Pierre-Robin syndrome is an uncommon congenital birth defect characterized by a triad of conditions, and it's also known as the Pierre-Robin sequence. It's known as a sequence because one component or finding leads to the formation of another, which leads to the formation of the third finding or component. Basically, it's a series of events dependent on each other. The first event in the sequence is the underdevelopment of the mandible as the fetus develops. This underdevelopment prevents the tongue from growing and developing in the correct location, forcing it to be pushed up and back into the upper airway. Because of this displaced location of the tongue, the palate is blocked and unable to obtain full closure, resulting in a cleft palate. And this is that triad of components associated with this sequence or syndrome. Underdeveloped mandible, leaving no room for tongue, pushback tongue, leaving no room for palate to close. So at the end, we see a micrognathic mandible, glossoptosis, which is just displacement of the tongue in the far back of the mouth, and a cleft palate. The exact cause of this condition is unknown, but there are theories that it may be due to increased pressure on the mandible or ill positioning of the head during fetal development, preventing the lower jaw from growing. There may also be genetic mutations or genetic ties to the condition. The most immediate and concerning complications of this condition are the infant's ability to breathe and feed. The retruded tongue may block off the airway and make it difficult to breathe, while the underdeveloped jaw, tongue placement, and cleft palate can all impede feeding. Treatment varies for the condition depending on how mild or severe it is. Sometimes the mandible will grow itself over time and treatment may be unnecessary, but more severe cases require surgeries to allow for breathing and mandibular growth. To answer this question, we need to think about the symptoms and physical features seen in these other syndromes. One of these syndromes often presents with similar facial abnormalities as are seen in the Pierre-Robin sequence, and the presence of this syndrome is also known to predispose a developing fetus to the Pierre-Robin sequence. The syndrome that is associated with this sequence is B, Stickler syndrome. Now, Stickler syndrome is a genetic condition due to mutations in genes that code for collagen, and it leads to connective tissue problems affecting the eyes, joints, facial structures, and ability to hear. This condition has an autosomal dominant inheritance pattern, and there are a few different subtypes of the condition based on the specific gene mutation involved. There's currently no cure for the syndrome, but treatment focuses on managing symptoms and preventing any further complications, such as retinal detachment, glaucoma, hearing loss, arthritis, cardiac complications, and neurological complications. Now, this syndrome is also thought to be a potential cause or trigger for the Pierre-Robin sequence in some patients. The defect in collagen that is characteristic of Stickler syndrome can interfere with the normal growth and development of the jaw, leading to the cascade of symptoms seen in the Pierre-Robin sequence. It's actually observed that many individuals with Stickler syndrome will present with some degree of this Pierre-Robin sequence, though not all of them will. And since we know that this syndrome is the answer choice known to be associated with the Pierre-Robin sequence, we know that the other syndromes are not associated with the sequence. But let's still go through the other answer choices and discuss what each syndrome is. And we'll start with Down syndrome, which obviously you've definitely heard of. In babies with this condition, they have inherited an additional chromosome at position 21 instead of just the pair that is typically seen, meaning that this is also known as trisomy 21. This syndrome is seen in 1 out of every 691 births, and the risk for this syndrome increases as the age of the mother increases as well. Symptoms of this condition include a flattened face, almond-shaped eyes that slant upwards, a protruded tongue, a short neck, mild to moderate intellectual disabilities, musculoskeletal and movement problems, congenital heart disease, and shorter than average height. Dental problems associated with the condition include delayed eruption of both dentitions, hypodontia, microdontia, macroglossia, malocclusion due to a small maxilla, and an increased risk for periodontal disease. Treatment for this condition involves a multidisciplinary team and is based on each individual's physical and intellectual needs. Because Down syndrome has no association with the Pierre-Robin sequence, we knew that this answer choice was incorrect. Next, we have Turner syndrome. Now, Turner syndrome, or monosomy X, is a condition that only affects biological females, as it is the result of one of a female's X chromosomes either being partially or completely missing. This congenital condition is seen in 1 to every 2,000 to 2,500 female babies, and it's actually the most common sex chromosome-related condition affecting female babies. The two most common characteristics of this condition include short stature and reduced function of the ovaries, but other symptoms include delayed growth and differences in sexual development, as well as physical alterations. Complications associated with the condition include heart problems, infertility, hearing loss, vision problems, kidney problems, hypertension, and pregnancy complications. Dental findings specifically typically include delayed eruption, changes in crown and root development, thinner enamel and abnormal dentin, microdontia, and malocclusion. There is no cure for this condition, and treatment is tailored to each patient's individual symptoms and complications, but often includes growth hormone therapy alongside estrogen therapy. And because Turner syndrome has no association with the Pierre-Robin sequence, we knew that this answer choice was incorrect. And finally, we have Klinefelter syndrome. This is also known as XXY syndrome and is a condition that only affects biological males. It is often underdiagnosed because the symptoms vary greatly from patient to patient and can be pretty mild. Typical symptoms seen in this condition include taller stature, infertility, lack of body and facial hair, reduced muscle mass due to lower testosterone levels, as well as learning disabilities. These patients may also develop breast tissue during puberty. We have Klinefelter syndrome. This is also known as XXY syndrome and is a condition that only affects biological males. It is often underdiagnosed because the symptoms vary greatly from patient to patient and can be pretty mild. Typical symptoms seen in this condition include taller stature, infertility, lack of body and facial hair, reduced muscle mass due to lower testosterone levels, as well as learning disabilities. These patients may also develop breast tissue during puberty, have hypogonadism, and other systemic problems such as cardiovascular conditions and autoimmune conditions. This condition is diagnosed via a karyotype to examine the chromosomes, and there's currently no cure. Treatment involves managing the symptoms, such as through testosterone replacement therapy and other physical and mental therapies. But once again, because Klinefelter syndrome has no association with the Pierre-Robin sequence, we knew that this answer choice was incorrect. So when talking about the Pierre-Robin sequence, we know that it is associated with Stickler syndrome and is not associated with Down syndrome, Turner syndrome, or Klinefelter syndrome. We have an 8-year-old male who's accompanied by a parent. His parent says his upper front teeth haven't erupted yet. He has hemophilia A, an X-linked recessive disorder that was diagnosed when the patient was 3 years old, and his parent assists with brushing his teeth twice daily. His incisors are palpable and covered with a fibrous gingival tissue, and he has gingival bleeding during tooth brushing. We're being asked, if the patient's father is unaffected and the mother is a carrier, what is the probability of a female sibling being a carrier? 0%? 25%, 50%, or 100%. Now this question really tests our knowledge of X-linked recessive conditions and how their inheritance pattern works. Now because the X-linked recessive condition in question is hemophilia A, I do just want to talk a little bit about this condition before jumping into the inheritance pattern. And thankfully, we're already being told that it is X-linked recessive, so we didn't have to remember that for this question. But because this is a condition that you should be familiar with anyways for the boards, I think it would be helpful to talk about. So hemophilia A is a genetic disorder that impairs the blood's ability to clot properly, and it leads to excessive bleeding. This is due to a deficiency in clotting factor VIII and is caused by a mutation in the F8 genes on the X chromosome. Symptoms of this condition include frequent and sometimes spontaneous bleeding episodes, joint damage, easy bruising, nosebleeds, prolonged bleeding after surgeries, and blood in the urine or stool. This condition can be mild, moderate, or severe depending on the level of factor VIII present in the blood, and treatment usually involves recombinant factor VIII as a replacement. But now let's go into the inheritance pattern for this condition, and honestly for any X-linked recessive condition. For a condition to be recessive, it usually means that it requires 2 copies of the defective allele to be expressed. But in X-linked recessive conditions, this is not always true. This statement would be But now let's go into the inheritance pattern for this condition, and honestly for any X-linked recessive condition. For a condition to be recessive, it usually means that it requires 2 copies of the defective allele to be expressed. But in X-linked recessive conditions, this is not always true. This statement would be true in females. If they inherit a mutated X chromosome from their mother and from their father, then they will have the condition. And if they only inherit 1 mutated X chromosome, then they would be carriers for the condition. And a carrier means that they carry the mutation but do not present with the condition. So they're carrying the gene, but they don't present with the condition. Now this statement is not true in males because they only have 1 X chromosome. So because they could only inherit 1, they will always be affected with the condition if they receive just 1 mutated X chromosome from a parent. This means that X-linked recessive conditions like hemophilia A are much more common in males. I do want to point out that because males only receive the Y chromosome from their father, any male with an X-linked recessive condition will have received that mutated allele from either an affected mother or a mother who is a carrier. On the other side of things, if a father is affected, then all of his daughters will at least be carriers for an X-linked recessive condition because on the other side of things, if a father is affected, then all of his daughters will at least be carriers for an X-linked recessive condition because they will always be receiving that 1 mutated allele from him. But let's jump back to the specific scenario given in this question. The father is unaffected and the mother is a carrier. We're being asked about a daughter or someone with 2 X chromosomes. That means 1 X chromosome will be coming from her father, and we know that he is unaffected, so at least 1 of her X chromosomes will always be normal. The other X chromosome could go either way. We know that her mother is a carrier, so that means 1 of her X chromosomes is mutated and 1 is not. And because it's a 50-50 shot which X chromosome the daughter will receive from her mother, there is a 50% probability of a female sibling being a carrier, making the correct answer choice C. In this scenario, which you can see depicted in the diagram, there are 2 options for the daughters. They're either unaffected or carriers, with there being a 50% chance for either one. For the sons, remember there is no carrier status, so they will either be affected or unaffected with a 50% chance of either as well. Now this is definitely the correct answer choice as this is the inheritance pattern for any X-linked recessive condition. But let's still go through the other answer choices and talk about in which scenarios these probabilities would be possible. We'll start with 0%. Now this answer choice should have been pretty straightforward. There will only be a 0% chance of a daughter being a carrier if both of the parents are unaffected. There are 2 allele combination possibilities for dad, affected or unaffected, and 3 for mom, affected, carrier, and unaffected. And the only combination of the 2 that results in a 0% carrier chance for a daughter is if they are both unaffected. So because that was not the scenario given in this question, we knew that this answer choice was incorrect. And next we have 25%. Now, because we're talking about sex-linked conditions, this is really not a possibility in a specific gender, as the inheritance pattern is binary. In other autosomally inherited conditions, there are 25% probability of things being inherited because offspring can inherit any combination of their parents' 4 alleles, 2 alleles from each. But because this is not true in sex-linked conditions, as females will always inherit 2 X's and males will always inherit an X and a Y, there is no 25% chance of an X-linked recessive condition occurring in a specific gender. If you wanted to not be gender specific and just look at a pool of 4 offspring, 2 male and 2 female, then there are scenarios where 25% would be carriers or 25% are affected, but it would never be gender specific. So since this question was gender specific, and because X-linked recessive inheritance will not result in a 25% probability for a female being a carrier in any scenario, we knew that this answer choice was incorrect. And now we have 100%. Now this answer choice is a little bit trickier than the 0% answer choice, as there are actually a couple of scenarios where the chance that a daughter is a carrier has a 100% possibility. If dad is affected and mom is not affected and not a carrier, then all daughters will be carriers. This is because the daughters will always be receiving the mutated allele from their affected father and will always be receiving one of the 2 non-mutated alleles from their unaffected mother, making every outcome be 1 mutated and 1 non-mutated X chromosome, also known as the carrier state. Another situation where there will always be a 100% chance of a daughter carrier is the opposite, where the dad is unaffected and the mom is affected, not just a carrier. In this scenario, a daughter will always get an unmutated allele from her father and will always get one of her mother's 2 mutated alleles, making her a carrier. So if one parent is unaffected and the other is affected, there is a 100% probability of a daughter being a carrier. But because neither of these scenarios were given in the question, we knew that this answer choice was incorrect. So when talking about X-linked recessive conditions like hemophilia A, the case of an unaffected father and a carrier mother, there will be a 50% chance that the female sibling will be a carrier.
This question asks, which is the most likely diagnosis? In the patient box, we can see that this patient presents with a fever, headache and myalgia, and painful bilateral swelling of the parotid glands. So the patient may present looking something like this, and this would be a case of the mumps, which is the paramyxovirus in the salivary glands. Patients with this may present with a low-grade fever, myalgia, headache, and potential anorexia. This is most commonly presented in the parotid gland. So looking at some of the other options, we have McCulloch's disease, which is a symmetrical enlargement of the lacrimal, parotid, and submandibular glands, which is not consistent with a fever. We also have pleomorphic adenoma, which is a benign mixed tumor of the salivary glands. It is slow-growing, painless, and unilateral, and since this patient has pain, this is not likely the correct answer. We also have sialolithiasis, which is stone formation within the ducts of a major salivary gland. This also wouldn't present similar to the patient box. We can eliminate this answer. So our correct answer is mumps, which means option B is correct in this case.
For this question, we're looking at a radiograph and we want to figure out which structure is indicated by the red circle.
So we know that we're looking at a panoramic image, and the structure within the circle is radiolucent. It's also found in the area above the oral cavity, and we know that it is air-filled because of the radiolucency. We can also see a mirror image on the other side, so we can assume that the structure does present bilaterally. So the correct answer here is the maxillary sinus. And the sinus is a radiolucent structure that is located in the maxillary region. It can have a round or pyramid-like shape, and it will appear radiolucent like what we're seeing here because it is filled with air. So we'll take a look at the other options and figure out why they are incorrect. First, we have the incisive foramen, which is a radiolucent structure, but we know that it differs in location and shape and size. So we can see it over here in the red in the image to the right, and we can tell that it is a fairly small structure, and it's found in the midline rather than on either side of the midline. And basically it's an opening which contains the nasopalatine nerves and vessels, and it's found in between the roots of the maxillary central incisors right under the hard palate, and this is where it will present in the panoramic radiograph. And we can see it indicated here in the red arrow. It can have a variable shape and size just depending on the angulation of the beam, but overall we know that this is an incorrect answer. Next, we have the hard palate and the floor of the nasal fossa, which are the same structure. And this is made out of bones from the palatine process of the maxilla and horizontal plates of the palatine bones. And these structures just separate the oral cavity from the nasal cavity, as we can see here. It is made out of hard tissue, so we can expect this structure to appear radio-opaque. Additionally, it does extend throughout the entire oral cavity, so we would expect to see the structure extending across the entire oral cavity in the pan, unlike what we're seeing here with the structure located just on one side. So it would be usually found right above the incisors across the entire oral cavity, and we can see it here highlighted in yellow. And with a periapical radiograph, we can see the floor of the nasal fossa as a radio-opaque curved structure that will extend from the maxillary incisors to the canine. So it'll have a different appearance than what we see in the pan. So now we know what to look out for when we see this structure.
erythematous rash across the nose and face, as well as these white striae with red borders on the buccal mucosa. And we're asked which is the most likely diagnosis. Now, we are given ample amounts of information to be able to answer what this diagnosis is, and some of these clues are pretty characteristic and should point you immediately in the right direction. We'll start with the fact that she has this erythematous rash across the nose and face. Like I said, this is really characteristic for a particular diagnosis, so we definitely want to keep this in mind, as well as the fact that we see these white striae with red borders. That's another huge clue. Honestly, everything in this patient box is a big clue. The fact that she has this joint pain helps us. Even the fact that she's female is kind of a clue. And what this patient definitely has is systemic lupus erythematosus. Now, lupus erythematosus is the most common collagen connective tissue disease in the US, and it has 3 forms, with systemic lupus erythematosus being one of them. And we'll focus on this particular form because that's what this patient has. Now, females are affected 8 to 10 times more than males. That's why I kind of pointed out that she was female, being a clue. And the average age of diagnosis is 31, which is also similar to our patient's age. So she's kind of like textbook for this condition. The condition has a waxing and waning nature, meaning it gets better, it gets worse, it flares, stuff like that. And it can cause fever, weight loss, fatigue, and even arthritis, which is why we see she had this joint pain. Now, it also has a very characteristic malar rash, and malar is just this region of your upper cheeks, your cheekbones, over your nose, and it's called a butterfly rash based on its shape, and it spares the nasolabial folds, which is where your nose meets your cheeks. Now, these skin lesions flare with UV exposure, and in these patients, we can even see renal and cardiac involvement quite often. But as far as oral involvement, which this patient does have, they can definitely have it, but it actually appears in 5 to 25% of patients. Now, these oral presentations may appear nonspecific, or they could be lichenoid, meaning they're similar to another answer choice that we see here, D, lichen planus. So they're lichenoid. They look like lichen planus. Now, they can be found on the palate, buccal mucosa, gingiva, and appear as these erythematous lesions with this white striae, exactly what we're seeing and being described. Now, we know this is the answer because of this characteristic rash in combination with these oral mucosal findings, but the fact that she was a female, that she had joint pain, they were also some helpful clues. Now, let's go ahead and go through these other answer choices, talk about what they are and how they're similar and different to our diagnosis here. And we'll start with sarcoidosis. Now, this is a multisystemic granulomatous disease of unknown etiology. Now, this inflammatory disease involves the growth of granulomas in different parts of the body, most commonly affecting the lungs. It's somewhat common, but oral presentations of this disease are pretty rare. Some oral symptoms that could present include desquamative gingivitis or oral facial granulomatosis, which is just like enlargement of the soft tissue in the oral cavity. There's also some reports of oral ulcerations, but like I said, this is not very commonly seen in the mouth. Now, how is this similar and how is this different from our lupus diagnosis? This is similar in the fact that symptoms of sarcoidosis and lupus are both quite broad, and they affect many organs and body symptoms. Sarcoidosis is also known to cause joint pain and even erythematous skin lesions, but it doesn't cause that characteristic butterfly rash that we see in lupus. Now, how are they different? Now, even though this can have oral presentations, it's incredibly rare to see oral presentations, way less common than that 5 to 25% of oral presentations that we saw in lupus. Now, the oral presentations may also not be seen as lichenoid-like we saw with lupus, and they never have those white striations that we saw. And this condition is also not more common in females. It's kind of seen pretty equally in females and males. Next, we have rheumatoid arthritis, which you've probably heard of before, but this is a chronic autoimmune disease where the body mainly attacks the synovium of the joints, leading to pain, stiffness, and swelling. This condition can also cause damage to other body symptoms, which I don't think a lot of people are aware of, but yeah, it can affect the skin, the lungs, the heart, and even the mouth. Now, how is this similar and how is this different from our lupus diagnosis? This is similar in that it's also an immune-mediated condition that's more common in women, and this obviously causes joint pain, which our patient actually has. This can affect other organ systems as well, just like lupus can, but it affects them in different ways. So how they're different is the joints in those with rheumatoid arthritis, they're not just painful, they're not just sore, but they get very stiff. They're characteristically stiff, which is not something that we see in lupus. They also have less common skin and oral presentations than what we saw in lupus, and they present very differently. So the skin may get these small lumps or nodules that form. It's not like a rash, and the mouth may become dry or have gingival inflammation. We're not seeing these lichenoid lesions, this white striae, these red borders. There's no butterfly rash or lichenoid oral lesions, so we know this is not the diagnosis, even though she did have joint pain. And finally, lichen planus. Now, this is kind of a tricky answer. If we're only looking at the picture and considering the description of the oral lesions, this could be kind of a trick answer. But we always need to make sure that we look at all the information in the patient box to make a complete diagnosis. Now, lichen planus is a chronic immune-mediated disorder that can be cutaneous or mucosal, with the mucosal being more of a chronic condition than the cutaneous. The cutaneous form of lichen planus presents with these purple papules with lacy white lines known as Wickham striae. So that's what we're seeing in this picture. These are typically found on the wrist, lumbar region, region, and the shins. Now, oral lichen planus has two forms, reticular and erosive. Both forms may occur alone or with these. Make sure that we look at all, which is not something that we see in lupus. They also have less, similar in that it's also an immune-mediated condition that's more common in women, and this obviously causes joint pain, which our patient actually has. This can affect other organ systems as well, just like lupus can, but it affects them in different ways. So how they're different is the joints in those with rheumatoid arthritis, they're not just painful, they're not just sore, but they get very stiff. They're characteristically stiff, which is not something that we see in lupus. They also have less common skin and oral presentations than what we saw in lupus, and they present very differently. So the skin may get these small lumps or nodules that form. It's not like a rash, and the mouth may become dry or have gingival inflammation. We're not seeing these lichenoid lesions, this white striae, these red borders. There's no butterfly rash or lichenoid oral lesions, so we know this is not the diagnosis, even though she did have joint pain. And finally, lichen planus. Now, this is kind of a tricky answer. If we're only looking at the picture and considering the description of the oral lesions, this could be kind of a trick answer. But we always need to make sure that we look at all the information in the patient box to make a complete diagnosis. Now, lichen planus is a chronic immune-mediated disorder that can be cutaneous or mucosal, with the mucosal being more of a chronic condition than the cutaneous. The cutaneous form of lichen planus presents with these purple papules with lacy white lines known as Wickham striae. So that's what we're seeing in this picture. These are typically found on the wrist, lumbar region, and the shins. Now, oral lichen planus has two forms, reticular and erosive. Both forms may occur alone or with these skin lesions, and they're more common in adults with a 3-2 female predilection. And as we see here, we have a female adult who is affected. It's usually seen on the bilateral buccal mucosa, tongue, and gingiva, but it can be seen on any intraoral surface or the lips. Now, like I said, there's two forms, reticular and erosive. Reticular, and I've attached a picture of what these both look like. Reticular is on the left, erosive on the right. Now, reticular is the most common, and it's characterized by these lacy white lines known as the Wickham striae that we see cutaneously, while erosive is more symptomatic, and we have these shallow ulcers, peripheral erythema, and these radiating white lines. So it's looking more like that reticular, but we do have some erosion. Now, this is usually treated with a potent topical steroid. Now, how is this similar and how is this different from lupus? Now, they're both immune-mediated disorders with skin and mucosal lesions seen. They're more common in women, and the oral presentations are practically identical. But how is this different? Now, the cutaneous lesions present very differently. We have these purple papules versus this erythematous butterfly rash, a different color, different presentation. And lichen planus is not associated with joint pain either. So even though the oral presentations of lupus are described as lichenoid, they're practically identical. That does not mean that this patient has lichen planus. She has other symptoms. We need to take everything into account. So like I said, when we have this patient, we see these lesions, we have this erythematous rash, we need to know that what we're seeing is lupus. The fact that she's female, the fact that she has joint pain, all of these things contribute. So make sure you're looking at all the clues when you're making a diagnosis. This question is asking, when should antiretroviral drugs be prescribed after exposure in order to help prevent an HIV infection? Within the first 12 hours, within the first 24 hours, within the first 48 hours, or within the first 72 hours? Now, this is a pretty straightforward question and is an important timeline for you to know if you ever find yourself in this unfortunate situation. Let's start by talking a bit about HIV, and then we'll discuss when these antiretroviral drugs need to be prescribed by. Now, the human immunodeficiency virus is a virus that targets the immune system, specifically the CD4 T cells. Signs and symptoms of HIV depend on the stage of infection. Initial symptoms include fever, headache, and sore throat, while later symptoms include swollen lymph nodes, weight loss, and diarrhea. Profound immunosuppression in patients with this condition can result in opportunistic infections, neoplasms, and other systemic effects. Head and neck manifestations are also very common in HIV and may even be the first sign of an HIV infection. There is no cure for this infection, but antiretroviral drugs are used to stop the virus from replicating in the body. If untreated, HIV will progress to AIDS or acquired immunodeficiency syndrome, and this occurs when that CD4 T cell count drops below 200 cells per cubic millimeter. And for reference, a healthy adult will have between 500 to 1500 of those CD4 T cells. Now, as far as transmission or exposure, this infection can be found in most bodily fluids and is usually spread via sexual contact or injection drug use. The bodily fluid with the highest risk of transmitting HIV actually is blood because it has the highest concentration of the virus. And when a needle stick exposure occurs, the average risk of HIV transmission is 0.3%. Now, this may sound very low, and it relatively is, but that does not mean it's a risk that anyone should be willing to take. Proper needle safety is very important, and in the event of a needle stick exposure to HIV-infected blood, the incident needs to be reported, the wound needs to be washed, and post-exposure prophylaxis or antiretroviral drugs may be indicated. Now, this post-exposure prophylaxis, or like I said, those antiretroviral drugs that the question is referring to, are most effective when started within the first 72 hours or 3 days from the potential HIV exposure. This is the full extent of the effective window, but theoretically, it's good to tell someone who has been exposed to try and take these medications as soon as possible to decrease any risk of infection. So because these medications can safely and effectively be prescribed for up to 72 hours after the exposure, we know that this is the correct answer choice. It's not within the first 12 hours. This is incorrect because although it is recommended to start this post-exposure prophylaxis as soon as possible, within 12 hours is a pretty impractical length of time, and it's not the actual correct window that a person has after a needle stick incident. And because of that, this answer choice was incorrect. Within the 24 hours was incorrect for the same reason. Although it would be great for a patient to have access to these medications as soon as possible, it may not be possible for them to acquire them this fast, and limiting the time frame to the first 24 hours does not account for the full accurate recommendation period. And finally, we have within the first 48 hours, for the same reason as 12 hours and 24 hours, within the first 48 hours is not the full window, so it's also an incorrect answer choice. So we know that when a patient is exposed to HIV, it is recommended that antiretroviral drugs should be prescribed within the first 72 hours after the exposure to prevent an HIV infection. 21-year-old male who has a sore mouth after yesterday's treatment. He's allergic to papaya and chestnuts, and he visited the dentist earlier to get a composite restoration on his lower right second premolar and his first molar, and we notice this erythema and these ulcers in that lower right premolar and first molar region. And we're asked, what is the most likely cause of these lesions? Now, before we talk about the cause, let's talk about what they are. Now, this patient is suffering from allergic contact stomatitis, which is an inflammation reaction of the mucosa due to a specific agent. Now, the list of agents that can cause this allergic contact reaction includes foods, oral hygiene products, and dental materials. And in this case, that's what it's from. It's from these composite restorations. Now, symptoms for this include a range from mild to barely visible erythema to extensive erythema, edema, erosions, and even ulcerations like we're seeing here. Now, this may be asymptomatic, but it can cause burning, itching, or stinging, just like we're seeing our patient is having symptoms. He's not asymptomatic. To diagnose this contact stomatitis, you need to identify the temporal relationship between contact with the agent and oral changes. So as we're seeing, this patient just had these restorations done yesterday, and that's why he's having these ulcerations, these lesions. If he had this done 3 months ago, he's not going to have this reaction. Now, although allergies to dental materials, and more specifically dental composites, are pretty rare, they are known to occur. And like I said, these don't occur way after the placement of the restoration. You're not going to get a composite a year ago and then suddenly be allergic to it. These reactions occur when a patient is briefly exposed to the resin material before it is fully polymerized. That's the important detail there. Once it's polymerized fully, it does not present any allergenic risks to the patient because they're not coming in contact with any of the released components of the resin. Everything kind of gets locked inside and solidified once it's cured. Now, this question is asking which of the specific components of a composite restoration is known for being responsible for this contact stomatitis. And although, of course, we're going to talk about all the answer choices a bit, this is kind of just like a buzz fact that you need to know which of these ingredients specifically, these components specifically, is associated with contact stomatitis. And in this case, that would be B, bisphenol A. That's what's really associated with this. Now, let's talk a little bit about the composite composition here, but we're not going to go really into the science and the details. Now, resin-based dental materials or composites consist of an organic resin matrix, an inorganic filler, and a coupling agent. Now, most of the commonly used composite resins in dentistry are light cured, meaning that they polymerize via light, that's how they cure, and they form a chemical-mechanical bond with the tooth structure. Now, bisphenol A, our answer choice, is the most common monomer constituting the resin matrix portion of the dental composites, and it's responsible for causing allergic reactions in susceptible individuals. So we don't use usually pure bisphenol A in our composites, we use derivatives, and they're known for having potential toxicity due to them being endocrine disruptors, but they pose no risk once the composite is fully polymerized. So once again, you need it to be fully polymerized. Because of this, efforts should always be made to ensure that the polymerization reaction while curing the composite resins has taken place completely. And the patient should be made to rinse their mouth with water once the material sets. You don't want this sitting on the gingiva and causing this allergic reaction. This will wash out any of that leak and reduce the risk of an allergic or toxic reaction. Now, for the other answer choices, these are other components of the composite resin matrix. And we'll talk about them a little bit, but what's important to know is that they're not associated with an allergic reaction. So we'll start with this tertiary amine. Now, in composite materials, the photoinitiator, which is something that we'll talk about a little bit later, allows the composite to be light cured. And it needs to be combined with a tertiary amine for polymerization to occur. So the photoinitiation system of a composite resin consists of this tertiary amine, which donates an electron. We're getting into the nitty-gritty here, but it donates an electron to activate that photoinitiator component, allowing for polymerization via the curing light. That's not super important. What you really need to know is that this is not associated with an allergic reaction, but it is part of a composite. Next is this benzoyl peroxide. This is a type of photoinitiator like we talked about, and it's used in certain composite restorations, but it's not the most common type used. This is what's combined with that tertiary amine in some restorations to allow for curing. And once again, what's important to know is this is part of composite and it's not associated with an allergic reaction. And then finally, this camphor-quinone. Of the composite components listed, this answer choice is probably just as important to know as that bisphenol A. Now, this has no association with allergic contact stomatitis, so you don't need to know it for that reason, but this is the most commonly used photoinitiator in dental composites. And knowing that may help you with a different question. It's not associated with this question, but it's an important detail to know. Now, this photoinitiator also contributes a lot to the color of the dental resin beyond just allowing it to be light cured. But once again, this is not associated with any contact stomatitis, so you don't need to know anything about that. So the answer here is bisphenol A. That is what is associated with that allergic contact stomatitis when a patient is having an allergic reaction to their composite restoration. So you want to make sure that you're always fully polymerizing your restoration so that they do not have this.